Oh, welcome back, my friends. Welcome back, my friends, to the show that never ends. And here we are. We were in Indianapolis. There's a big meeting called the FDIC. It's a big fire department based meeting. And we've been asked to talk a little bit about the medical stuff in our meetings. And we've been doing lunch and learns, as they call them, which we've been putting on here at Eastern Time, 12:15 every day. So that's in a room that's a couple rooms down from here. So you'll see about that time, I'll be making a transition over to that room. And in the meantime, we'll touch on a couple other subjects. One of the ones that I thought would be really a cool thing for people to hear about is the recent adventures that Crawford has had. And Crawford Meacham, our medical director, our Eagle from Philadelphia, has actually had a longstanding relationship with the folks over there in Israel and had made a lot of visits and learned a little bit about their system over the years. Hopefully he'll tell us why or how that all started. Um, but he also had a more recent experience over there in Israel and in the Gaza. And so we want to learn a little bit about what his impressions were from that. So I thought it'd be kind of an interesting topic. I was hoping to get Peter on as well because he has relatives there who were involved and quite frankly killed. Not close relatives, but people who are related to him. So it's just a interesting circumstances. So I wanted to get a medical director's perspective about that. And so with that, Crawford, you want to take it on?
Sure, I'd love to. And in just to start out, I apologize. None of our offices in this building have ceilings to them, so there's always a lot of background noise, but I will sort of try to work my way through it.
Yeah, you're sounding
Um,
good so far, so it's good.
so just a little bit of context. So sort of like Paul mentioned, I'm not Jewish. I have no connection to Israel other than many years ago, and I think it goes back to about 2005. I made my first trip over there with a few other medical and law enforcement people on a little delegation sponsored by an Israeli company that was intended to show us kind of how Israel had been dealing with their various medical and terrorist security threats over the years. And I kind of fell in love with the country and became fascinated by all the issues that they were dealing with then and continue to deal with. So I basically been going back every year since then. And the company that arranged the original trip has sort of become the people there become sort of my friends, and they coordinate my trips. They sort of give me access to things that a lot of people don't have access to. And so anyway, my latest trip was literally about 3 weeks ago. And to put it in context, my previous trip was intended to be the week after the October 7th attack. And
Ah,
big surprise, it got put off because there
ah,
was a war going on and like
yeah.
rockets were flying everywhere. Um, but that being said, so I got pushed off to last March. And so this was, and last March, I visited all the various sites that had been attacked and met with hospitals and EMS and stuff. And so this was sort of a follow-up visit to that. And this is kind of what Crawford does for vacation, which is kind of a sad thing, I guess. Um, but anyway, just to show you my timing going to Israel is rarely very good. I flew there from Newark the very same night that the U.S. staged a fairly massive airstrike on the Houthi bases in Yemen. And so when I arrived in Israel, the Houthis were pissed off. And so this was my first exposure to rocket attacks towards Israel. And so during the week that I was there, rockets were coming in from Yemen, from Gaza, as well as from Hezbollah in Lebanon. And this was my first exposure to the red alerts, which are the sirens going off in the middle of the night, which tell you should go flee and hide in a shelter somewhere. And being in a 10-story hotel in Tel Aviv, the shelter was actually the stairway. There's like probably a shelter down the basement somewhere, but I figured if anything was actually going to happen, I'd probably be dead by the time I got there. So all of us
Ah,
kind of huddled in our pajamas and stuff on the stairway, hoping we didn't get blown up. But fortunately, the Israelis are fairly good at shooting these things down. And for the tech savvy among you, you can actually in Israel download apps for your cell phone that'll tell you when rockets are being launched, and they make all sorts of horrible noises, and you can sort of specify what location you're staying in. And since I was traveling all over the country, I pretty much put everything in. So my red alerts on my phone were going off all the time to the point where after a while, I just sort of stopped paying attention to them. But anyway, that's just a little bit of context. One of the first places I visited what's called the Gaza envelope. So it's the communities right around the Gaza Strip. And I think it's like literally within about two or 3 miles of Gaza. And I went to a kibbutz down there, which was fairly heavily impacted by the October 7th attack, where 5 people were killed, 5 people were abducted by Hamas and taken to Gaza, and 10 IDF soldiers were killed. Most of the residents hadn't moved back. You'll see some signs of rebuilding down there, but still there are a lot of houses just that are empty and just riddled with bullet holes. And I met with each of these communities down near Gaza has a security force that's private, but its only mission in life is to secure those facilities there, those communities there. And met with one of their security people who had responded on October 7th in there and was in firefights with the Hamas folks coming in. And that continues to be his job to this day. Other places I visited, and this is all kind of random thoughts and experiences and stuff like that. Israel's small enough that it has a national fire department. So I met with their chief medical officer at their facility fairly near Tel Aviv. And they have a gorgeous facility training area up there. And the fire department actually, not surprisingly, I guess, played a very active role in October 7th and the subsequent war, because a lot of rockets were hitting southern Israel and setting places on fire. And so the fire department was responding at times under rocket fire to put out fires and also to rescue people. And I met with the chief medical officer for their national police department as well. And they too, not surprisingly, have been quite busy in the past year and a half, both initially on October 7th and during the subsequent, sort of high level war going on, just fighting the terrorists. And sort of to this day, there's still a lot of security threats that the police are dealing with. And both organizations, you can tell all of them, everyone in Israel at this point sort of seems to be having PTSD, which is not surprising. And it's certainly very prevalent among the fire folks, the cops, and as I'll mention, also among EMS. And so that, just dealing with post-traumatic stress and resilience building are huge issues for those agencies, as well as for the entire nation. Another place I visited with, and some folks may know this organization already, it's called Zaka, which is a search and rescue organization. It's a UN recognized humanitarian organization founded in Israel probably about 20 or 30 years ago, following one of the intifadas over there. And it initially was intended to respond to terrorist attacks and to collect and identify the bodies and ensure that they're buried in accordance with Jewish religious law. And that's kind of their main mission to this day, but their scope is expanded to the point where they do EMS response. They also do search and rescue response both in Israel and overseas. And so Zaka has responded to earthquakes and volcanoes around the world. For those of you who remember the 2021 Surfside, Florida condo collapse, Zaka flew there to help recover, identify the bodies, and make sure the Jewish folks got buried in accordance with Jewish tradition and stuff like that. And also for those of you who remember the synagogue shooting in Pittsburgh back in 2018 that Ron Roth had responded to, Zaka flew to that for that very same reason, just to make sure the killed were treated respectfully according to Jewish religious law. So that was Zaka, and I visited Magen David Adom, the national EMS agency in Israel. There's several EMS agencies, but the national one is MADA. And among other things, MADA runs the National Blood Bank. And for the pre-hospital blood folks, they actually don't use pre-hospital blood there in a civilian population, but they supply blood to the IDF. And so not surprisingly, they've been supplying a lot of blood to the IDF down in Gaza. But I visited their blood bank. They have a national blood bank at MADA's headquarters, which is fairly close to Tel Aviv. And it's the world's first underground anti-missile blood bank. So it's not something you normally think about when you develop a blood bank, but this one has to deal and protect the blood supply, both from rockets and stuff like that, and potentially from chem bio attacks. And so this gorgeous facility it's 3 stories above ground, and above ground they have they have a breast milk bank, and they have they have administrative areas and stuff like that, but it apparently goes down like 6 stories underground. And the deeper you go, the deeper you get to the actual blood supply, which is on the bottom level. And also on like the second floor underground is a whole ChemBio air filtration system, so people can continue to operate within the blood bank and within MADA's headquarters while under a ChemBio attack. And they probably have some of the biggest blast doors in the world, once again, just to make sure the blood supply underground is secured. And just a couple other things. I don't want to belabor all of this. It's just sort of a kind of a few closing thoughts. It seems like everyone in Israel knows of someone who was killed or kidnapped on October 7th, or knows of someone. It's such a small country. It's like 2 generations from someone who was killed or abducted there. Everyone, like I mentioned, seems to have PTSD of some form or another. So this is a big priority. Fortunately, as you know, some of the hostages have been returned, and some of them after a year or so. And so that's creating a lot of different issues, things that people really haven't had to think about for quite a long time. But a lot of these folks have been undernourished, starved at times for close to a year and sometimes longer. And you may have seen that in some of the recent hostages who are released. And so the medical centers that these places, these folks are taken to, and they have a few designated sort of destinations for the returned hostages, have to sort of think about the whole issue of refeeding and refeeding syndrome, and how do you start feeding again the chronically undernourished. And so they're sort of developing an area of expertise that really hasn't been needed for quite a long time. You sort of think about Holocaust survivors and stuff like that. And another issue is just dealing with the psychological trauma of these returning hostages who lived in captivity for over a year, who were all under constant threat of getting killed either by Hamas or by an Israeli airstrike or something like that. And also, a fair amount of the hostages were kept underground in the dark for prolonged periods of time. And so once again, just sort of the psychological issues are humongous. And while things have gotten better there in Israel, the tempo of the war is decreased. But as you know, just from the news, the fighting's still going on. Hezbollah has been, surprisingly silenced for the most part, but they're still launching rockets. Hamas is still trying to flex its muscles a little bit. There were, as you probably heard, over 500 miles of tunnels built by Hamas in Gaza, and a lot of them are still intact. And so they may still have some arms left and places to hide. And like I mentioned, also the Houthis are still sort of acting up. And while attacks from Yemen have a little bit more lead time, and Israel can often shoot down the rockets, it's not 100% guarantee. And finally, no one's ever really quite sure what's going to happen with Iran. You probably remember when Iran launched over a couple hundred missiles at Israel last year. It could happen again. So more to come. It's a lot of interesting issues and very sad issues to deal with over there.
And did you have sort of your own personal fear or concern that you're there and something might happen to you during that period of time you were there? Sounds like it's possible, right?
I've been there so many times, and I figure I'm old and I'm expendable and I don't really care. I think that part of my brain never really developed or something.
That's how I always think of you, Clayton, and Clayton Crawford. I always think of you as being old. Yeah, I'm being sarcastic. Hey, but you bring up an interesting point. It's a small country. We may think it's a country, so it's this large thing. But I'm going to tell you, the fourth smallest state in the United States is New Jersey, and it's got 8,700 square miles, and Israel is about 8,500 square miles. Just to give you an idea that you could fit Israel within the state of New Jersey. You may not want to do that, but whatever. But it is interesting. So and it's a tough situation.
Yeah.
What were the vibes? I don't know, maybe you can't talk about it politically, but what was the vibes amongst the rescuers and those you were taking care of in terms of the ongoing things? And do they have their own concerns about, the innocent victims here and all those kinds of things? And is there kind of the thing where you have twisted thoughts about, what's right or wrong or what's good or, that kind of thing? Yeah, it's had that sense, because that must impact upon when you say everybody's got PTSD, that's probably a big part of it. I would guess.
Yeah, it's complicated. Peter, I see you popped on. I was going to mention I was in Sderot Nerim and thinking about you. But that being said, not being Jewish, it's a fascinating country. Politics are amazing. If you think our politics are complicated, Israeli politics are that much more complicated.
Yeah. Yeah.
Yeah, I think people are concerned about innocent bystanders in Gaza, but the question is trying to figure out who those innocent bystanders are. And
Yeah.
once again, so many people have lost, so many Israelis have been directly impacted by this that there isn't like a whole bunch of, there's certainly no sympathy for Hamas. And it's kind of not always easy to find sympathy for the rest of the people in Gaza. It's sort of like who are the innocent and who are not. And it's a very difficult thing to distinguish. And looking at polls, you've probably seen polls that show like the majority of Gazans support Hamas, but that may also be under duress because I think Hamas is perfectly happy to kill their own civilians if they need to. And you may have seen there were some protests over in Gaza in the last couple of weeks, and allegedly, purportedly, some of the protesters were subsequently killed by Hamas. So it's a very complicated place, and Peter can probably attest. The more you go there, the more I go there, the less I seem to understand.
Yeah. Yep. Yep. So, I don't know if you want to make a comment, Peter.
Sure.
Don't feel obligated, but
Yeah.
let me.
No, first of all, Crawford,
By the way, I
it
just
means
have
a
to
lot.
tell you where Peter's talking from up the hallway here. It's great. Okay, go ahead, Peter.
Now, first of all, I wanted to thank Crawford. I know you've been someone who's gone there. You've seen it for yourself. It's very difficult for people who have never been there. Don't understand what these little kibbutzim look like, how close they are to the border, how long they waited until they received help. Unfortunately, that was a big gap there. If you look back, the family members of mine who were killed, their family has since come to America, and they're literally we're in Indianapolis now, but they've come now to Hollywood, Florida, because they just like the PTSD, the whole thing, just wanted to get away from it, because the entire family died, and they're like ghosts when you look at them, right? We saw them recently; they're like ghosts, and I think Crawford, you're right. The entire country is so small, as Paul mentioned, that when you live in Israel and you have to go to the army because the only way to protect that land is to go to the army. It's a very different feeling than in America, where you never have to worry about war, you never have to worry about going to the army. So like there, it's a different mentality, and Paul and I have seen how difficult it was for Parkland, after Parkland, for our community to, and we're still screwed up in our head, but imagine what happened there. That's happening to the entire country.
Yeah.
So very grateful for you. I'm scheduled to go back in June for a week. And I'm hoping to get to heal a little bit by going there as well.
And this is, of course, laid on over centuries and like last century's miserable attacks, and you feel kind of surrounded there, and it's a tough situation. But anyways, the thing that I take out of this is that when people whine about that they had to pay a little bit more for eggs or this or that here in our country, I just sit there and go, are you kidding me? They're not dropping bombs on us, right? Like my parents were telling me about when I was growing up, about the people in London or even up in Northern Ireland and various places like that. It's just a whole different, you don't know how good we have it, etc. So, all right, enough of that.
And I've mentioned this before, but despite all of that, I still feel like Philadelphia is probably a more randomly violent place than Israel is.
Okay. North and south, right? And you have planes dropping in on you every once in a while, right? So, all right. I do want to we only have a couple minutes left before the top of the hour, and I wanted to get Clayton on board to announce what's happening out in California. So, Clayton, you want to tell us real quick, and we'll get reaction from Eric and John and Randy?
Yeah, I'll put my camera on so you guys in the East Coast can see what the sun looks like. It's actually kind of cool. It's warm too. So the California programs, we have a collaborative we call CalDrop, which is 5 California counties: Ventura, LA, San Bernardino, Riverside, and Sacramento. We're live in 4 programs right now in Corona, LA County, Compton, which is also within LA County, and Ventura. And Ventura became the first program to actually to transfuse a unit of whole blood yesterday to a stabbing victim with arterial hemorrhage. So
Nice.
I would love to take credit for it, but it's our neighbors to the north. And but they said that the patient's clinical status improved dramatically after the unit of whole blood, and we don't know the final outcome yet, but no, it's exciting. We had little friendly wagers going on about who would be first.
Yeah, but it's still great that you're giving them credit and announcing that, and as usual, that's your way. So good for you. It's really cool.
Yeah.
Very good. And then, all right, any reaction from your guys' end? Either let's start with Randy and then Eric and then John.
I am super excited. Small note, Clayton, I don't know if Eddie had told you that, you know, we hammer down working with the blood bank in the hospital, but apparently the patient stabilized so much that the trauma surgeon actually took the blood bag and the paperwork and walked it down to the blood bank to make sure they got it.
Cool.
Awesome.
Eric, any comment from your end? Eric LeBanc? Well, maybe audio not working. Okay.
Yeah, I'm here. Sorry.
Okay, good. No problem.
Yeah, I mean, again, it's just you watch these programs go and it's awesome. You know, the friendly wager part we get, but everybody's supporting everybody in that 5-tier system. 4 up, one's getting pretty close. It's just an amazing collaboration of work amongst this group and then the folks out in California.
Good. And then John, any commentary or any news or anything else to report from the coalition end?
No, that's fantastic in the LA area. I got an email, Clayton, that I'll be sharing with you. You may already be aware of it, but I heard this morning that the trauma surgeons out there have identified a state legislator who is very interested in proposing some legislation. So we'll put you in touch with those contacts.
I had not heard, but I look forward to seeing it.
Yep, I'll get it to you this afternoon.
Okay.
And LA County and Compton are doing our first blood bank exchange in about an hour and a half. So
very cool.
Hoping that goes smoothly, but I will say the device manufacturers have been spot on. We use the APRU refrigerators and they have been, knock on wood, they have been bulletproof.
All righty. Oh, that's good news. Let's then move on to some other topics. Lori Reeves, just so you're aware, we're going to have a nice presentation on OBGYN, well, OB largely, laborious tests, right? As I said, later, probably around, hopefully around 11:20. Oh, that's right, East Coast time, around 12:20, 12:40 that you're over. You'll see why in a second. But I also wanted to let you know that the Surgeon General of California has agreed to come to the Eagles meeting and talk, and hopefully you'll be there as well. I thought, and we'll talk more about it later. I just wanted to give you that feedback. I just heard from her last night. So, okay. And you made that happen. So thank you. All right. Let's see now. Let's try to see if there's anybody else that had to walk over. Okay, let's then move on to other things. Well, first of all, Vicente, do you want to just quickly introduce yourself and tell them a little bit about your background, both in Madrid and then later now in Iceland? And I'm talking about like a 1 minute, just here I am, and we'll have you give more of a presentation about the size of the country and how the number of population and, the number of responses, how you do it'd be nice to learn about your system if you don't mind, but we'll give you some time to prepare that. But you want to just come on and say hello to everyone?
Hi. Thank you, Paul, for sending the invitation here to the Icelanders in North Atlantic. Hi to everyone. So my name is Vicente Sanchez Brunete. I'm an emergency physician, originally from Spain. I worked there most of the time in the pre-hospital system in Madrid, one of the largest in Europe. And then a decade ago, I moved to Iceland. I'm based now in Reykjavik. I'm medical director of the EMS. There's an EMS medical direction for the whole country.
Yeah.
And
And it
Yes.
sounds like you have really good teamwork with Vidar, who had been your predecessor in that job, being the national medical director and Reykjavik, et cetera. So from our point of view, we're going to say you're the eagle for Reykjavik, right? And so we're glad to have you join us. I know you already have a existing appointments in June, and you were going to come visit us otherwise, but Vidar will come down, I think, and so your country will be represented there, and it's great because we learn from each other so much. There's bunches of people on this call that are way smarter than us, and yet they're so kind and they're so good, and they learn every week from this meeting. So I'm glad you got to be on it. How's this been so far? It's been interesting.
Yeah, really good. I'm just listening and learning a lot. Thank you.
Okay, good. Hey, Mick, anything you want to add in? Because you know most of the folks around that part of the world.
No, I don't think there's anything to add. I think it's a challenge in an island when you've got only a couple of big hospitals and trying to provide a service in a very widely dispersed community. So you're going to
Yeah.
have a lot more challenges than probably you're aware of in the States in doing this. And then
Absolutely.
you've got the constant flow of air traffic over the country as well, where every now and again you have a volcano that goes up and that affects the air traffic, and you can have a lot of planes grounded. Suddenly you've got lots of people on land or on the island with
Yeah.
complex medical needs that you hadn't planned for.
So Vicente, just why don't you let me know, in a couple of weeks, 3 weeks, whatever you want to do, or you can do it next week. I don't care. Just let if you'd like to do kind of a quickie presentation about your services and, and what you've learned so far, because it's kind of new for you as well. But it'd be kind of a fun experience there and to learn about your country. So, okay, well, thanks. Welcome.
Sounds like a plan. Okay.
Okay, good.
Thank you, Paul.
And then one of these days,
Paul?
let's just you and I get on, we'll talk and, it'd be nice. Yes, go ahead. Who's that?
Yeah, if we can share emails, I can get data from Iceland, if that's okay.
Oh, yeah. I think, he should be on the invite list at the very bottom. You'll see, because I added him in last night. Okay.
Very good. Thank you.
Yeah. If not, then, I'll get it to you. Just let me know. So just so you know, that, Vicente, that the, Dr. Augustine is our kind of he's just been my hero. He's our kind of librarian, as we say. He keeps the records. He accumulates, what we do. And it looks like we are responsible for about 1/3 of the US population amongst this group. But the interesting thing is we don't look at that as some kind of bragging thing. It's more the other way around. Like, we're accountable for all those people and we got to get it right. So we look forward to helping each other out. And so same thing with you, I'm sure. So, okay.
Sure.
All right. And Jim, you want to quickly, you want to present the RAND thing maybe next week, or you just want to give us an update, just or a 30-second elevator pitch?
30-second elevator pitch. The RAND report came out this week on the finances of emergency care, focused on commercial insurance and how it has not paid for the care of patients who they insure. If you have a chance, it's a long report. The summaries are very quickly that insurance companies have used the No Surprises Act to not pay for emergency care.
Yeah, No Surprises Act. I like that.
How's that for 30 seconds?
The NSA, you did fantastic. Hey, you want to, if you have it, is it something you could put into the chat in a PDF or something?
Yes, I'll
Okay.
do that.
You are the best as usual. Thank you. Anything you need to report from as the medical director for IAFC? Anything to report from your end? Or
yeah, the IFC is going crazy because of the loss of the National Fire Academy, the shutdown of the U.S. Fire Administration, education, research. They reopened the 9/11 health office. They had closed that temporarily, but IFC, IFF, all of the fire organizations are involved. Paul, are you up in Indianapolis at FDIC?
I am here. Yep, I am here. Yes.
That's what I figured. Big attendance, I understand.
It's amazing. Yeah. So, and we're going to go and see part of the attendance in about 10-15 minutes. We're running a show over there, and I'm going to put them on and have them see how we do our stuff here. So it'll be kind of fun for them, I think.
Excellent. Thanks, Paul.
All right. No, thank you. And then, Kevin, anything to add to that, by the way? Sorry if you guys got to be prepared. I will be calling on you, just not like that sometimes, right? Is it? Yeah, I didn't know if Kevin was on the call, wasn't he? Jim? I thought. Maybe not there anymore. Oh, yeah, here it is. Kevin.
Hi, Paul. I'm sorry I'm working a shift, and so I'm talking
No,
to
no,
a
I was talking
nurse
about
behind
Kevin
me.
Joels. It's Kevin
Oh, I'm
Joels.
sorry.
Yeah. So, but it's good to see you anyways.
Good to see you too. I'm multitasking like we all
Yeah,
do.
if you want, I'll call on you later just to bug you, okay?
Great.
How's
Thanks.
things in Sacramento while I got you on? Anything new there?
It's great. Yeah, our transport to alternate destination program is really going well. We're actually able to navigate many patients away from emergency departments, making an impact locally.
That's great. And I think we sent that out. Peter, did you get a copy of that, by the way? Because you're having that issue in Brevard County trying to find alternate. Did you get all the information that he sent
Yes.
out?
Yeah, that was amazing. Thank you so much, Kevin.
Okay,
You're
good.
welcome. Thanks.
And New York City, same thing, right? Right, Glenn? All right. So let's move on to one thing. Do you want to talk about the credentialing issue and, want me to set it up a little bit, David? By the way, that was the strangest thing that Christine sent me last night. So should we show it here or is it?
Sure, you can show it, whatever.
Yeah, but
My
you got
firemen always,
it just pops out of nowhere, that kind of thing. So
my firemen always try and beat me up. Yes.
I got to see if I can find it now. Okay, but you know what? It may have come in a
Text.
it came in a text. I don't know. We'll see.
Text.
Maybe it came in a text. Maybe it did.
Text came as a text.
Yeah. Okay. Good. Let me see my text here. So I have to, is everybody able to see this? Okay. So yeah. Oh, here it is. That's her.
There it is.
Yeah. Look at that. What is it, David? It's an action figure. It's pretty funny. And you got whole blood. What's this? Just the EKG monitor, right?
Yeah, there's a Zoll and a life pack. Yeah. So one of my Jordan Gowie actually is the government affairs guy at STRAC.
Yeah.
He got some weirdo website and started making these from pictures for all of us, and I just laughed. Then my son took that thing and put the Subway logo and said "Eat Fresh" because I look like John on the Eat Fresh Subway.
Hey, so Nick and Peter, do you think it'd be immodest of me to show what happened at dinner the other night here? What we found on the table?
Oh no, yeah, you definitely got to show that because
Okay,
I think we all got inebriated on the name on the name drink.
Yeah, this is the whatever you call it, the the comic relief moment, right? So let's see. So first of all, we got invited to dinner here by the organization to eat a place, and guess what they call it? Here's the direct. It's a rooftop restaurant at the Hyatt called the Eagle's Nest. So totally appropriate. I have to say they didn't name it after us, but it was just coincidental, right? There's the access to the restaurant. And it's the best romantic restaurant. We didn't have any romance, but it was a good time that we had there. But when we saw there on the table, there was this specials. It has like the fire stuff, like for the firefighters, etc. It has some logos, that they were trying to, show there. And then when you look closer on the menu, right, you want to tell them what it says here, Peter, and you had one, right? Okay, ooh, here we go.
I had many more than one, Paul. Yeah.
Okay,
it's the Dr. Pepe's Nero Manhattan.
Which I told him that misnomer, David Miramontes would tell you it should be Manhattan Nero. When you say it in Italian, the adjective comes at the at the end. Yeah, so it was great. So it was really kind of fun to see that. It was very, very flattering. It was nice. They're good place. We had a good time.
Thanks to you. I'm drinking again, Paul. So it's no good.
Okay. All right. So fun things of the week. David Miramontes, right? Yeah. And it was amazing because Peter always has his old fashioned, his smoked old fashioned. So it was very, really cool that happened. All right, David. So let's go ahead now. So David, we're all facing the same kind of problems in the sense of we got to get troops out there, but at the same time, we got to make sure they pass muster for the medical directors if we're going to be responsible for them, right? So, and by the way, as you give this talk, I'm going to probably be personally shifting over to another room and plugging this into a large screen while you're doing that. But so I don't know, I don't know if you have a new fire chief. I don't know if you have pressures from that or what's getting on, but tell us what you're facing and then tell us what you're doing about it. And I'm going to go silent for a little bit here as I switch over. Okay. So thanks.
Yeah, thanks, Paul. All right, so as you
and let me interrupt you for a second. Just for those who are new to the call or whatever, David Miramontes is the medical director for San Antonio, Texas. Now, I had previously been in other cities, including Washington, D.C. for a very long term. And so we're just lucky, and he's doing a great job down there in San Antonio. So go ahead, David.
All right. So we, our fire chief exited stage left 2 years ago. And so we've been in like this leadership vacuum. And so who was really running the department was the deputy city manager, who's a fiscal hawk. And she, let me tell you, she's brilliant. She has a photographic memory like Paul. And she found every little dirty secret in our budget. And so as such, there was a lot of budget pressure on the remaining chiefs. So we started looking at our credentialing process. So we have firefighters that are firefighter EMTs for years and years and years, 4, 5, 6, 7 years. And then they promote as an engineer, and then they go to paramedic school. So they do their 6-month Monday through Friday paramedic school. They do their ride outs as part of the school, which is in my shop. And then after they pass the registry, then we have to teach them how we really want them to be paramedics. So they go back to boot camp for 2 weeks, and then they start ride outs with field training officers. So what we are finding is when my partners and I were trying to sign them off during the medical director interview, they just weren't ready, and that they had not had exposure to the kinds of patients we wanted them to have before we kind of set them loose. So we really had to kind of do some soul searching and really look at our process more carefully. So it started out with operations. We wanted to make sure everyone passed the registry before they started boot camp, because the boot camp is different protocols than what they'd be tested on the registry. And then, so we had to make sure that was being done right. Then we had to make sure that their training during those, we do 7 shifts was what it was before. And it just wasn't enough. 7 24-hour shifts is not enough to make sure they have all the skills of these high training medics. And so that's why I did that survey. What is everyone else doing? And what did I find? I find out it's all over the place. Right? From a couple shifts to 6 months to a year in Austin, for example. So it's all over the place. So to be honest with you, I don't know what the right number is. I do know what I want to see. I want to see probably 10 shifts. I want to see them run a critical patient, a trauma patient, a cardiac arrest. I want to make sure they, not just understand the protocols, because, people can memorize protocols, but I want to see that they can function as an operator in my environment. So we're bumping up the required shifts slowly. And let me tell you, my operations people are extremely upset about this, because, that's extra time where they're a third person not on a truck, and it, racks up overtime. But it's just, we just have to do it. So this has been a real struggle for us. A lot of internal soul searching on our process, a lot of changes in how we do things, and more importantly, how we document things. So we use the Power BI, otherwise known as Agency 360, as our electronic portal that we use to document all the stuff. And it's been very helpful, but we even are changing it to document better what experience they actually have before they are allowed to come to the medical director for their interview. So anyway.
Dave, I gave you the right answer in the chat there. The right answer is 8.7. That's so you don't have to worry about that anymore. And fixate on the number.
Yep, got it. Yeah, and it's all over the place. And I think that's what I wanted to hear, is that everybody's doing it differently. And then maybe, and I'll be honest, we're an outlier, we're on the lower side, but I needed this data to try and help, knock my fire chief up a little bit to make this a little bit better. So truth be said, I have a great fire chief. She's fantastic. I have a great EMS chief who actually is promoted. He's now at the assistant chief level from being a bat chief. So we're raising the bar, so to speak, for EMS. Now, the funny thing is that I always say this, but my fire chief cringes when I say it, is we are an EMS department that does fire very well, because 85-90% of what we do is EMS. So that's why we're kind of raising the bar. And I was surprised at this process, because my paramedics are not high school paramedic school, jump on the truck. They're been in the department for many years, and then they promote. So they've been in the department for 8, 10 years. So they had a lot of operational exposure. But even with that, going to this new role as a lead medic was different, and required a different decision-making matrix that I don't think they appreciated until they started getting into the job. So anyway, that's what I learned from this process.
David, Mark Worth just sent out the survey again because we didn't get as many surveys as we wanted.
Yeah.
So about 10 minutes ago, he just resent it again to a wider range of addresses.
Right. And when you do that, you guys, in the other, put the number. So if you put shifts 7, if you put months 4, in the other column, when you go through it, put the number, please. Okay, that's all I have, Paul. Oh, you can't, he's not on mute. He's on mute.
I made the transition over. Peter, are you talking now? Huh? Okay, got it. Can you guys hear me out in the audience here? No, you can't hear me. Okay, I'll get on in a second.
Loud mic.
Microphone. Okay, give me just a second. And while does anybody have any you know, on the Eagles, anybody have any questions or comments to add to this? Or have you been through this problem before? Anybody want to pop in and talk about that? Yeah, go ahead, Mark, please.
Yeah, no, we actually don't use a number of shifts because we recognize that not all shifts are created equal, and not all patient contacts are created equal. So we actually require a certain number of ALS intervention contacts. And I think the number is too low myself, but because we only require 10 ALS contacts. But for some of the folks that can take, 1 or 2 shifts, and for some it can take 15 or 20, depending on where they're at.
Okay, yeah. Okay, sounds good. Anybody else want to contribute anything into that? I guess.
Yeah, can you hear me?
Yeah, Rob, go ahead. Detroit.
Yeah, so we've also been struggled with this kind of all over the map. I mean, we do more of like what Mark was talking about, like for our EMT Academy, you've got to have exposure to this many things. And then we do like some competency-based assessments. So you could hit those earlier than later. So it's not a specific number. We do a very similar paramedic, we have our own paramedic class, and even paramedics that we hire, we make them work as basics, even if they already have a license. And then we put them through a paramedic promotion process. Somewhat like Dave's. In fact, I think some of what I use, I think I originally stole from Dave from DC from years ago. But I think that really looking at that, a shift doesn't equal a shift, that we really want to make sure that we're using, procedures, exposure to certain cases, kind of like what we do with emergency medicine residents, right? You've got to have X number of things and not just put a time on it. Because I too ran into what Dave ran into, where I would have people come for the medical director kind of scenario-based assessments. And some of the people were like clearly had a lot of real world experience, and some of them had just memorized stuff and really didn't get it and weren't ready to do that. And we had to send it back out there. So I do think that the more we look at this, the more we can find a better way to do it.
All right. And then the little thing, I'll take part 2 on this. sometime, David, especially after you get your evaluations back. Good. Meanwhile, we've actually made very time. Maybe let's have you set up in the meantime, Erica. I guess I have to do a thing where this is going to be an interesting experiment to see if I can tell you. And we'll try to show you the audience as well in just a second. Let's see it. So I got to go share, and then I'm going to go. Multiple people can do it. Okay, so try to Eric Van Duzen, if you can, please go ahead and try to plug in for our audience here and see how that works. Okay. And that's it. All right. And then I may be walking around the room, folks, so you may not be able to give me, so just ask me questions. I won't be able to monitor it. There we go. Excellent. All right. Let me tell the audience here at the meeting here in FDIC in Indianapolis what we're planning to do and how this will be different from what we've done the last couple of days there. Okay. So, okay, I think we could do. Hey, Eric, can you talk to us? Let's see if it's echoing or is it okay to hear this?
Sure, Paul, can you hear me okay?
You hear them okay? Yes. All right, good. Okay, sorry for sound good. All right, good. Okay, Eric, stand by. You're gonna have to
I was gonna tell you that Matt has the camera overlooking the audience, so everyone can see the audience.
Okay.
Through his camera.
Okay, got it. All right, so this is the large group that you had last couple of days. I'm glad you guys all came back. How many people are new to this? Never been here before, right? We're probably going to do another person is off at a meeting, not going on. So we're very kind of busy, but whenever they can, we try to get on the call. One of the things I thought was interesting to talk about, and that's what we do, and they always do, and other things, the last couple of days, their mom and yesterday. I love today, I'd like to launch into a really kind of cool thing about one of the main things we're really talking about lately. Has been dealing with very enabling emergencies, that there's pre-hardened or post-hardened. One of the things that we wanted to remind people about that we started on to this whole track about 2 years ago is that sometime 20 years ago when the season we just started everything close to the door, but maybe we forgot. We spent 2 months ago, whatever, and so then or the patient we ignore it and feel that if it's someone who is very hard and that's something to treat right away. So even on that. And then where we want to do more and more into other procedures, particularly after and what is out in some, I don't know what I'm saying, that would be called OB that's a scale of taken to it and good. And one person who is transfer say we're not using. And Eric is up in the South Dakota area, right? Eric, you want to know a little bit about that and then just try to hear about why it's a problem for you? Is that okay? All right, good.
Yeah, I don't think they can hear you so well, so here, let me just get on here and let everything go. All right, Eric, you're on, bud.
All right. Well, thank you, Paul, for having me today. I guess this talk really started with Dr. Peter Antev, who invited me to do a podcast for him on OB. And my background is I'm a paramedic in South Dakota. Was a flight paramedic for several years, but I also ran a mobile simulation truck, and we did simulations for EMS fire as well as in the hospital. And I was one of the few guys that actually like to do OB. And so I'd actually do OB training in the hospitals with their nursing staff and a lot of times even obstetricians. And so got to fly with the maternal team. And so just wanted to, I do a lot of education on it, and even had a high risk OB nurse from Indianapolis at one of my sessions in Indiana here not too long ago. And she's just like, it's really cool that there's a dude that wants to do this, especially a paramedic, because we don't see that. And you're spot on. I wouldn't change anything about what you're teaching on. So that's always good. So my presentation is called Heading Out because, oh, here we go. We know most babies head out, and just be appropriate. I have a twisted sense of humor. You have to if you're in fire EMS. So I always image this as babies start to come out. Usually I try to put someone's face in there that I know, but want to be appropriate. 90% of all deliveries really go without much compromise. But the one thing that, and it's pretty simplistic, we're there to assist in the process. And to David's comment, when it comes to training medics, and we can train them how to take a test, but we don't want cookbook medics. We don't want cookbook providers out there. They need to come up with some differential diagnosis and some high risk things, because it's a low frequency, high risk event that we're getting called for. And I spent a little time in Vegas training medics in the Valley out there. And they had an obstetrician come in and talk about labor delivery. About 50% of deliveries in Las Vegas post-COVID are done at home with midwives, doulas, whatever. When you're getting called to those, you're probably getting called because things went sideways. And so you have to come up with a differential diagnosis and the problems that you're going to encounter in the field. So typical sample history for EMS, one of the most important ones for me is medications. And the reason being is we've actually seen in South Dakota, there were a lot of females that were on antidepressants, and because of the dosing of the antidepressants, it caused some respiratory compromise when baby came out. And so you need to be prepared and get that information to make sure that you have a good baby. There was a study from 2010 to 2017 that showed that there was a 131% uptick in marijuana use and substance abuse in females. But they really didn't see any detriment when it came to babies. However, a study came out in 2020 that showed 1 in 6 babies are born with neonatal absentee syndrome. That's 1 every 54 minutes. And so you're going to have a higher tendency to be able to see those babies, and you have to be able to make sure that you have the resources available because if something goes sideways with mom and then you've got a baby that's not acting normally, you've got to be prepared. You may have 2 critical patients in 1 rig. You may need some additional resources to figure out what's going on. Ectopic pregnancies, 70% of them out here on the ambulatory. And otherwise, you can have an ectopic pregnancy about anywhere. And when you talk childbearing age, you're talking 8 to 50. It's everywhere in between. So any female of childbearing age with abdominal pain, you have to rule out an ectopic pregnancy first and foremost. One of the conversations I had with Dr. Antevi is this DES was actually the very first drug scam in the United States. It was used from 1948 to 1971 to help mitigate some problematic OB issues with moms. And what they've seen is their offspring are now having complications, and it actually just being exposed to that is going to increase a chance for an ectopic pregnancy. But because of the time frame, that's actually going to come out of the slide deck at some point in time because it's not going to be pertinent. So, but be aware of those ectopic pregnancies when you're out in the field and dealing with any females with abdominal pain. Cord complications, we need to watch for this. They're not uncommon. And there's some things that we can do to help with that. Put the pelvis in elevated position, bladder emptying, which isn't going to happen in the EMS world very much unless they've done it before us. We can give tocolytics, and so we can get the uterus to relax, and so they're not pushing and bearing down, have them breathe through their contractions and such. But this is the one time we're going to take a gloved hand and we're going to insert it into the vaginal canal to prevent the head from engaging so it does not compress the cord. I did a scenario once and I had 5 physicians with a cord presenting. All 5 physicians were pushing the mannequin down the hall with the warmer and everything else, and all the nurses are like, this guy must be pretty cool to get 5 physicians and no nursing staffing playing this. We went down to the surgical suite and moved him over, and that scenario got really weird because ended up with malignant hypothermia due to anesthesia as well. So I don't wish that upon anyone on a bad day. So, but if you can at all, try to avoid the palpation of the cord, just because it can cause some complication, vasoconstriction, and make things worse for baby as well. Now, one of the things that I was always taught in paramedic school a number of years ago is there's 2 things when we talk about the placenta previa, which they may have bleeding but no pain, and then placenta abruption, and they'll have severe pain but no bleeding. So placenta previa just depends if they've had neonatal care. Sometimes you can have a low-lying or a partial placenta previa, but as the uterus grows, it can migrate out of the way. You can still deliver these in the field if it's coming, but any female that has bright red bleeding and 0 pain is more than likely placenta previa. You're not going to, unless you have ultrasound in the field and you're used to looking at those things, we just need to get them to the hospital so they can look at C-section for the delivery of those. Sometimes it's just going to start happening and you're going to have to adjust accordingly. Now, placental abruption, like I said, I was always taught, because this is typically what we're going to see, is that starts to abrupt at the decidua basalis, where the ovary or the egg implants into the uterus itself. That's the weakest point. There's 4 different deciduas within the uterine wall as birth is happening, but it starts to pull away, and as the more blood actually accumulates in there, it starts to abrupt. Again, I didn't know this until later on, that you can actually have placenta abruption with external bleeding. That was just one of those things we were taught. It's one this or this, and it's not necessarily true. You can actually see placental bleeding, or that bleeding externally with that. The difference is that they're going to have some extreme pain with it. So you have to make sure that you do your differential diagnosis between the 2. And then we'll also talk about postpartum hemorrhage here shortly. Cuvular uterus, also known as uteroplacental apoplexy, is associated with placental abruption. I actually had a maternal nurse that ended up with one of these. Depending on your research, roughly 95% of these cases are non-life-threatening. Only about 1% of those are life-threatening. And the one that we had, she needed a total hysterectomy, needed blood products, the whole 9 yards. And what actually clued the maternal nurse into it is she started to massage the fundus, and as she's massaging the fundus, and you're not going to see this in the pre-hospital setting either, but as she's starting to massage the fundus a little bit, the abdomen started to turn ecchymotic, or you started to see bruising there, which we don't normally see, and you can get pretty aggressive in doing that, which clued her in, and then there was a lot of bleeding to tie into it. So there was a little bit of postpartum hemorrhage, but fortunately blood products, tocolytics actually saved this lady's life in a total hysterectomy once they got there. So it also increases their risk of developing a PE. So just something to keep in mind. One of the other things that I learned, one of the things I learned about some other placental complications is, you see here in the slide, you have a normal placenta, it attaches to the endometrium. You can end up with placenta accreta, where it just grows through the endometrium, the placenta increta, which grows into the myometrium, and the placenta percreta, which actually goes clear through the uterine wall and attaches to organs surrounding it, oftentimes the bladder. And so if the mom's complaining of having urine in the bladder, we're thinking kidney issues or something like that. But if she happens to be pregnant, we might be thinking placenta percreta. And again, you're probably not going to know any of these unless they've had prenatal care and they're telling you about these things. But it's going to set you up for a high risk situation if she delivers in the field of having a postpartum hemorrhage. And they're seeing a higher incidence of of these around the country. And so you're going to want to make sure that you have some additional resources, blood products, tocolytics, and some tools in your truck to be able to manage these particular patients. Surprisingly enough, I was the EMS chief in Yankton in the southeast corner of South Dakota. In the first month and a half, we actually had a patient that had placenta increta that we were transporting out. So it does happen. Nothing happened during transport and everything went smooth. And I don't know the results of what happened there. Preeclampsia and eclampsia, often we really don't know what causes it. Just we have always attributed it to mom just wanting to having kind of an allergic reaction, if you will, to the baby, and it only ceases once she delivers. The problem with that is it's several weeks. Typically, we see it about 24 weeks, does not reverse until after the delivery, which I just mentioned, and it sets them up for some bleeding complications later on as well. But we're looking for blood pressures of 140s over 90s. Both numbers are important. And really, this is the one time, I'll be honest, don't worry about treating hypertension unless we're having a hypertensive crisis in the field. But this would be the one time if they're symptomatic and we know that they are preeclamptic, that we may want to start giving them some medications to bring their blood pressure down slowly. We don't want to drop them or tank them. But we're looking for that hypertension. Proteinuria used to be one of those findings that physicians looked at. That's kind of coming off the list. But we can look for pedal and sacral edema in these particular patients, photophobia, headaches, and then that right upper quadrant pain because it starts to affect the liver. There's 2 helper mnemonics that we talk about when it comes to OB patients. One comes with preeclampsia and eclampsia. The help mnemonic is hemolysis, elevated liver enzymes, and low platelets. You're not going to know that in a pre-hospital setting, but this is something that if you're transporting interfacility, they can probably give you some information on this. But we want to keep the patient in a left lateral position, try to keep them desensitized to audible and lights and those things to prevent them from becoming eclamptic. A little bit of O2. And then if we have ALS units, we can consider MAG, which is a pretty common medication that we give in the pre-hospital setting. Some of the systems are starting to carry labetalol, so we can start to give them labetalol to bring their blood pressure down. We can also consider hydralazine or nifedipine if you happen to carry those within your system as well. Do me a favor, cervical dilation and effacement. It's not an EMS scope of practice. We should not be doing this. As I presented for Dr. Antevi, there were a couple medics who were fired in Ohio a number of years back for sexual harassment. They did a cervical effacement dilation check on a pregnant female. It's subjective anyway. I could take a group of 20 medics or 20 EMS providers and have them do a triage of multiple patients, and they're going to be slightly variable. Again, it's subjective. Don't set yourself up. Look at your signs and symptoms, the way your patient's presenting. The baby's either coming or they're not. And so just set yourself up for success. Shoulder dystocia, we look for that turtle sign depending on the size of mom. Sometimes you can see bulging the perineum, or as she has a contraction, the head will actually start to present. And as the contraction goes away, the head goes back in or the bulging ceases. One time is probably okay. If you start getting 2 or more, we have to have a high index of suspicion that the patient's having shoulder dystocia. And we need to start doing maneuvers about every 30 seconds to mitigate this. But keep in mind, it doesn't have to be hard. Put a McRoberts, so legs backing out as far as you possibly can. And if that doesn't work, let's just get the pelvis to move. Let's bring their legs down and in, and then go right back up. Just get them to move around a little bit. My stepdaughter recently had one about 2 years ago and had shoulder dystocia. She was doing a bath delivery. How do you move a 300-pound pregnant female out of a bathtub easily and quickly? It doesn't happen. Fortunately, just getting her to move her hips to roll over was enough to get the shoulder dystocia to resolve. And we have a 2-year-old grandson who's healthy and fine, but we want to make sure that those complications we're doing something to mitigate those. Now, with that being said, one of my last slides will talk about this. We're not there to pull babies out. We're not delivering calves. It's mom's job to deliver them. So here's the helper mnemonic for us. We're not going to do episiotomies in the field. That's for your physicians. But McRoberts, external pressure. And this is the external pressure. You're always going to push down and in kind of towards baby's nose. We're just getting that shoulder to roll. And then depending on your medical director, there's a couple other ones. We've got Rubin 2, where we're basically inserting fingers in the vaginal canal, trying to get that shoulder to pop around, or would corkscrew maneuver, where we're just basically lefty loosey, righty tighty. Don't pull too hard. There's an actual measurement of force that we can apply. It's 30 to 50 newtons, which is roughly 6 to 11 foot-pounds of pressure, which is really the equivalent of someone pulling a tennis shoe off. It's not much. Mom's got to deliver these babies because we don't want to cause harm. We don't want brachial plexus injuries, Erb's palsy. We don't want to internally decapitate babies. Sometimes we got to get a little aggressive with moms and get them to deliver these kids because they get tired. So, and there's your brachial plexus injury there. Postpartum hemorrhages. We're looking for tone, trauma, tissue retention, and thrombins. Treatments, we've got a list of them. Depends on what you carry. PIT, Cytotec, Methergin, and Hemerbate are the first 4 meds that they're going to be using in OB suites. Most EMS agencies don't carry them. We do carry TXA, and that's a new one for us. We're starting to carry blood, as Ventura was the first county in California just the other day that started to give whole blood products, so good for them. And then we can consider manual massage or Bakri balloon or Jada. Now, I talk about Bakri balloon and Jada. It's not going to be in our scope of practice that I see anytime soon because the equipment is just not feasible. But keep in mind, postpartum hemorrhage moms can bleed out in less than 8 minutes. So it becomes like a trauma patient. So we have to be stepping and fetching and thinking of what's going on with them. Here's a Bakri balloon, basically tamponades the uterus until they can take them to surgery and figure out what's causing the bleeding. The problem with this device, it's one-time use only. It runs about $3,500. Again, high risk, extremely low frequency event. And so for us to be proficient at utilizing this device would be counterintuitive. One of the newer devices that's out there is the Jada. The Jada is hooks up to a portable suction device. It's got its own suction unit. Basically, and just absorbs all the blood that's coming down through the uterine, through the bleeding, and basically suctions the uterus to that device until they can decide what they need to do. So, APGAR score, keep in mind this is retroactive. I don't know many people that are actively sitting there looking through the APGAR score. It's always something that's done absently. So, but keep in mind we want to assess babies to make sure that they're doing well, and if not, we need to do something to intervene. So this is a big one for me. The shiny Schultz of the placenta really doesn't play a part when I'm assessing this at all, but the Duncan side that attaches to the uterine wall, this is the side that I'm looking for, because if there's retained tissue, there's typically 13 little lobules on this. If they have retained placenta, it's setting you up that there's retained tissue, which is going to set them up for a postpartum hemorrhage. Again, 500 mils for a vaginal delivery, 1,000 for a C-section. 500 mils doesn't look like much, especially when a lot of that can be sitting up in the uterus without you seeing a lot of it externally. And it may look like a normal delivery. And all of a sudden, mom's going to go soft on you to pressures and stuff are going to tank. So that's all I have, unless anybody has any questions. I wanted to be respectful of everybody's time, and thank you to Paul for the opportunity to present on this, and Dr. Antebi.
Yep. So let me see if I got to figure out how to do the unshare here. Sorry about that. Kind of screwed this up. Okay, someone did it for me, I guess, right? So good. Thank you very much. If I can get out of this. All right, good. So it was really nice. It's kind of a nice refresher for our audience that was here. And I thought it'd be good to have a didactic on a different topic than we've been doing the last couple of days. And So I appreciate you. So does anybody have any questions, either from the audience or any people on the call? Or is there anything you would add to it out of the Eagles group? Anybody at all? Okay. Anybody in the audience have any questions? So, yeah. Yeah. The question we have here is that, is it, you said Pitocin, you said, or what? Oh, Topolytics, yeah. Okay. I don't think so, that I was aware of. Yeah.
I don't know. Yeah, so the question is Topolytics. You're talking about postpartum? Yeah. So there is some EMS systems are carrying, and ACOG recommendations are to give something like Soprostol or something like that post delivery. But the problem is it tends to be such a low frequency event that people bring TME.
Yeah.
But yeah, the common Topolytics are already mentioned.
All right.
The other thing that we think about is if you have to effectively get to transport these patients while in early labor, is having that plan to be, for rapid precipitous delivery.
So one of the things I wanted to bring out here is that I think that I don't want to, this was a little bit long than we usually have, but I mean, it's fine. But a couple of things that struck me with this is that when you have the thing, oh, pain, no bleeding, it's this, and it could be either way. So not to get suckered into that. And that's one of the main points we have here. The other thing I wanted to bring up though, Eric, was the issue. I was hoping that sometimes you have to transport a long way to get someone to a center that can, a center of excellence for OB problems if you have complications, correct? And what have you done about that?
Well, I live in a rural frontier part of the country. A lot of my transfers are an hour and a half. You may have flight, you may not with specialized units. And so you've just got to be prepared and have conversation with your sending and receiving physicians on those. But you want to make sure that they're aware of that. The hospital system I worked for in Vegas, they actually had like a code magenta, which was like a code blue, but it was for postpartum hemorrhage. So the entire team is coming. And when you're transporting those patients, an example of a postpartum hemorrhage, be thinking of what they're going to be doing, that continuity of care. What are they going to have at that receiving hospital, whether it's your primary or secondary, to mitigate those issues that we don't have for tools. We need to manage them in the initial, but be thinking long-term. It's like taking an MI to a stroke center. You've got to take them to those special centers and try to do as best as you can. And sometimes it's phoning a friend and making sure that you have those additional tools available and you're trained on them.
Okay. Anybody else have any questions or points they'd like to make on this before I move on to rolling on? Yes, go ahead. Yeah. Can you go back to Topolytics? I guess I have to give you a share again. Okay, here we go.
Right, so that's correct. So that is a Topolytic is something you would give to staff. So that would be something like Tubulinum.
So I think maybe we're talking about different things.
Can you repeat the question? Why don't you repeat what she's saying?
Okay, so.
And then.
Yeah, so just to clarify.
I might not see it now.
The statement was about Topolytics. I was thinking about Neurotonics, but for Topolytics, we're pretty limited pre-hospital in what we can use. There's TER, MAG to some degree, and things like that.
All right, then at this point in time, I want to kind of go around the room real quick and see if what's happening in the various cities around the country. I don't know, Vidar, if you can get on or not. I'll try to get you on with us. Same thing with Ray Fowler out of Dallas. And so if you can, that would be great. But let me start going around the room here and see if we can catch some of the folks that are on the call still before we all have to I have to disappear fairly quickly myself. So Eileen, anything we need to know in the world of by the way, this is Dr. Eileen Marty. She's a distinguished professor for many years, worked with us in Homeland Security 25 years ago, and is she keeps us on track. She works for the World Health Organization as a special advisor, and she keeps us up to date on various things that are going on. So if you don't mind, Eileen, anything we need to know about in the world of infectious disease at this point, quickly, since we gotta go around the room.
Right, there's obviously we're still fighting the measles. That's a continuing problem, and now we're seeing cases. Sorry, there's an emergency beep going on here. I'm gonna have to go. I'm so sorry. Gotta go.
There's some bell ringing somewhere. I'm trying to figure out who's doing that, so we'll see. But go ahead. I think someone figured out they had their bell ringing. But go ahead, Eileen. So you're talking about measles.
Well, I think that was Eileen. I think she had to go to respond to that arm.
Yep. She left.
Oh, we lost Eileen? Is that what happened?
Well, she had an acute emergency she was called to, Paul.
Oh, is that what it was? Okay, well, never mind. John Jew, are you on?
You taking a
can be,
break?
as an infectious disease specialist, you can help us.
Yeah, I'm on here. Can you hear me, Paul?
Yeah, so John Jew is our Eagle from Portland, and he's also an infectious disease specialist as well, board certified. John, go ahead.
There's I think Eileen was sort of saying we're continuing to have a measles outbreak. That's nothing really new, mainly in Texas. The other one would be there was an H5N1 death in Mexico. The first, just to remind everybody, there has been one North American H5N1 death that was in Louisiana, a 50-year-old. The second one was a recently reported on Tuesday, a 3-year-old in northern Mexico, I believe. Don't have much history in it, but they had a previous, Mexico had a previous H5N2. And so that's sort of the something to watch out for. It's not quite clear why or how the 3-year-old got sick and died right now. That's about it from an infectious disease point of view.
Okay, anything new in the realm of Portland that you need to tell us about, or everything okay there?
Nothing new in Portland.
All right, let's jump over to the Big Apple, New York City, since you always have something going on there. What's the latest, Glenn, in New York?
Good morning, good afternoon. Our call volume maintains at about 4,500 a day. It's crushing to us, but we're maintaining that. Yesterday,
So
unfortunately,
4,500. So you haven't gotten to 5,000. So you're only at 4,500, right?
well,
Okay.
no, we've actually hit 5,000 as well. So anyway, yesterday, unfortunately, we had a Tor helicopter crash into the Hudson. It actually crashed more on the New Jersey side, but when the reports came in, we weren't sure. We sent out resources. Unfortunately, the pilot and a family of 5, 2 adults and 3 children, were all killed. 2 children were actually transported to the New Jersey hospital, but it was not successful. So it was a pretty tragic event for us.
All right.
Hey, Lynn, it looked like it was spiraling in. What happened to that?
Yeah, it seems to indicate that the rotor on top was already disengaged from the helicopter, and it kind of twisted and just fell upside down.
I thought maybe the tail, I don't know if it had a tail rotor or not, but if it did, that maybe it went out or something.
Yeah.
Sometimes if pilots overcompensate, that can happen. It's just kind of interesting. So, well, anyway, too bad. Hey, Ray, can you check if the bell is coming from you? Because you keep lighting up. So I just don't know if there's something in your background there.
I'll just go on mute. Okay.
Okay.
Let's
Thanks.
see if it goes away. I'm so sorry.
Well, where we have you there, anything new in Dallas? Yeah, it did go away when he went.
Yeah, we've recently started blood going on. Welcome, by the way, to the home of measles in the world right now. But it's good to know that the vaccine is now recommended. If you heard the news over the weekend, never mind. Satire gets nowhere. But we're here, and life goes on, Paul.
And Dallas, there is a I just want you to know there was a podcast about you, Ray Fowler, about how you helped to be the primary founder of NAMSP, the medical director's course, Eagles, everything. So as the first
Paul, if I had not been following you around back in the 80s, I don't know where I would be.
I did describe the fact when I walked out of the phone booth in 1984 on March 3rd that you were wearing a striped red tie, a powder blue shirt, a blue jacket, and khakis. And they was wondering how I remember that. And I said, you never forget Ray Fowler. So,
And at the end
all
of the
right.
conference at noon, the attorney who was on the dais there, and we were saying that we ought to begin to put this together. He says, "Oh, you want to form a club?"
Ray had the first laptop that I ever saw. Hey, let's go over.
I'm trying to find it, by the
let's
way.
go. Let's and then if you could mute yourself, Ray, it'd be great. And let's go down to Nashville. Jared, anything we need to know about anything new happening in your realm?
Nothing huge. Apropos of all the conversation about OB and maternal deserts, there's a big push statewide to get some NRP training out there. So in the next 2 weeks, we're going through some in-servicing and trying to get most of our folks through NRP training. So that'll be good.
Okay, okay, good. Let's speaking of which, let's just jump over to Denver. Jacob, anything to report out of your realm?
No, nothing significant at this time.
Yeah. And then, and by the way, Mark, your name, Mark Gautreaux in San Jose, your name came up last week because, well, at this conference here a couple days ago, because we were talking about how you decrease wall time and, you know, or ambulances ramping, whatever we describe what Mick would tell us, you know, that kind of thing. But it just doesn't seem to happen at your hospital. Can you tell our group here what was some of the secret sauce for you not having that happening in your area?
It basically, it comes down to the culture of the institution. And nursing administration for the emergency department really focused years and years ago on developing a culture that trying to make sure patients avoided waiting. And so I worked last night actually, and when you have nurses really making an effort to get patients moving and get patients seen, I saw all of my patients I saw in the waiting room because we've now assigned a physician shift for 2 shifts that is entirely in the waiting room. And so
let me ask a question then. Why are your nurses able to help you out? Are your staffing different? Do you pay more? Is it just a greater environment to work in, or
It
what do you
is.
think?
It is we do pay more. It is one of the highest compensated nursing positions around, and we actually attract nurses from across the country who commute in. We have nurses commuting from North Carolina and Utah and Colorado, to name just a few. And it is just a very collegial culture. They hire nurses who are really engaged, and it's really kind of on them that we keep things moving. But it is considered fundamentally immoral to hold an ambulance from the public with a patient on board. And the nurses, you ask the nurses, geez, this must be really hard. And they say, no, it's not hard at all. You know, most of our patients come in by ambulance, go to the waiting room because they can. And we have a 75 bed ED, and they said, there's always a bed opening up within a few minutes, either an admission or a discharge going home. And it's just not that hard to match incoming ambulances with someplace to put them.
Now, Peter's asking us, he said, are there hallway beds upstairs? Are you doing that?
We will do that under very rare circumstances, but because we have mandatory nurse ratios in California, we're pretty limited on how much we can board upstairs. It's usually, you know, we've usually declared a disaster, internal disaster, to get that to happen.
Okay. Got it.
We have a huge number of patients in the emergency department, though.
All right, let me move out to Hawaii, and where we have Libby Char, who's been not only the medical director for Honolulu and Environs, but also as actually the Secretary of Health for the state in the past. And then you were asking a question, Libby, and maybe we can get an answer. Go ahead.
Yeah, we've joined the other 22 states that have cases of measles. And so we're just reviewing our protocols and whatnot. And I know you're supposed to vent a room for 2 hours after somebody with measles is in that room, but it doesn't seem feasible to pull an ambulance out of service for 2 hours. And if you're actively venting the rig, I just was wondering if anybody has data on how long you need to vent that rig before you can put it back in service.
Which is probably a long time because that will just sit in the air for a couple hours. John, I think you're the best person to address that.
I think, Libby, I think the 2 hours came from previous studies about 10 or 15 years ago, at least. What I would use to do is actually have a UV environmental unit that we actually have in Portland that can infect that apparatus. I'll send you the links offline, Libby, on that device. It's not that much as well.
Okay.
So
Yeah, we have
UV light.
We have the UV light devices in Honolulu, but not in the other counties. And I was just wondering, I mean, I would think the 2 hours is for passive ventilation, but if you're actively ventilating or, you know, get the doors open, fans on, something like that, does anybody have data on how you can shorten that time? Because I would think you'd turn the air over in the back of the rig and pretty quick if you're actively ventilating it.
Yeah, you're correct, but I'm not aware of any data right now that would basically take the ambulance service liability off as well. So I think so the real issue there is you're absolutely correct. I think you can clear the air in the ambulance fairly quickly for obvious reasons. But I think the real issue there is data. I'll look and get back to you if I find any other data, Libby.
But the ultimate thing is
Thank you.
actually the whole issue of making sure people had it, the real actual disease itself, like you and I did, John, back in the day, or
Yeah.
that they got vaccinated properly, they're up to date, or they have the double vaccination if they're gotten their one shot in the 60s or whatever, and then to look out for the pregnant paramedics, et cetera, all those kinds of issues. That's the basic thing in the first place. So, all right. But I love this extra additional help that we need because we got to protect the next patient, right? All right, let's move on to a couple other folks that are on here that I wanted to talk to. I didn't know Jenny and I didn't know if they're gone out of Baltimore. You know of anything going on, Matt, in Baltimore? If Ben's not on, I think we probably lost Ben.
Couldn't find any data that we could tackle out. A lot of sense. We're actually using hydrogen peroxide aerosolization system.
Okay. Or it looks like we're getting pretty much over our usual time, so I'm going to probably cut this off. But Mick, anything to report out of Dublin?
Just in following on from your ramping discussions and hallway boarding, we've got a new initiative from our Department of Health, Secretary of Health, that we have to do updated observations on people in the waiting room who haven't been seen yet. I would have thought the priority should be trying to increase the sizes of the emergency department so people don't have to spend a long time in the waiting room, but now bringing in a thing where they're looking for 20,000 staff to go and upskill in how to update observations and manage and observe people while they're waiting to be seen, rather than putting the effort into putting more resources into where they can be seen.
Okay. Well, great to see you, and thanks a lot for helping out with Kathleen, by the way. I really appreciate that help. And so let's see. I think we better wrap it up here at this point in time because I've got already, 3 minutes past the hour. But we're going to continue a lot of these discussions next week. And welcome back, my friends of the show that never ends. Sheree, thanks for joining us today, by the way. And hopefully we can get back to you later if there's anything new from you to report from us, and Roger the same. But I just got to get everybody out of here. So with that, see you back next Friday, everybody. Thanks for being here.
Thank you.
Thanks, Paul.
Okay,
Thank you.
Paul's trying to shut this down. I think I'm in charge. I got to figure out how to do this now. Hang on. Okay, end meeting for all.